can give it a few minutes. And Jesper's joining. I know, yeah, I hear from our group that some people watch later. So, even though we may not have as many people today, I think a lot of people are on spring break and things. So, yeah, but have you been, Jesper?
Hey.
Good.
Yeah, pretty good.
Good.
Busy. It's busy times. A lot of meetings. And
Yeah.
is it for you as well?
Yeah, it's been busy here. A lot of things, and medical student teaching's coming up and
Yeah,
things
exactly.
like that. Yeah.
Overall good.
Yeah.
Well, we can probably proceed,
Yeah, I'll just do a brief introduction to some our next few weeks. Here's the thank you everyone for joining. And I really appreciate it, and we look forward to the special speaker today. And I really appreciate everyone's participation. We have some things coming up Kim and I were talking about, so stay tuned. We have a lot planned. The next couple of months, we do have speakers. Kim is going to speak in 2 weeks on the simulation hypothesis, and there'll definitely be more to come on that. Sounds really interesting. On May the 11th, Alex Lupe is planning to be in Edmonton. And he may drop by, but if not, we'll figure something out for that May the 11th. I think that on May the 25th, Pinaki Sardar is going to present. So we look forward to that. And then we'll skip on June the 7th. That's the American Transplant Congress Week. I think a lot of people are traveling around that time. I will be. So we'll just go ahead and postpone that week. And then Jesper, I think you'll sort of begin our summer, late spring, early summer. So thank you for I really what you presented the last time I heard you speak was new to this group, several of the things. So I think whatever you're able to do will be appreciated. So thank you so much. And I'll get with Richard. I know he's going to speak at the American Transplant Congress, I believe. So and I know he spoke at USCAP too, so maybe whatever he wants to do. And Priya actually joined today too, and I've been wanting to pin down a date for you also. So I'd love it if I've heard you've done amazing work on whatever you want to talk about it, but I heard on multicolored staining and also on the AI collaborations that you have. So we'd love to hear from you on those things. And if anyone has any suggestions, I have some potential speakers on AI ethics and large language models. If you have any preference, I can try to find some speakers because I do have some candidates, but I just haven't reached out to them yet, but I can definitely do that. And any other comments right now?
Thanks for keeping this going along, Brad.
Yeah. Well, and and then we'll thank you all, and we're going to keep it going. But today we really look forward to Jana. I don't want to take any more of her time and give her as much time, and then also potential time for discussion and such. So thank you so much, Jana. I'll turn it over to you.
Thank you so much. Let me share the screen. Do you see the presentation right now?
Yes.
Okay.
Yes, looks great.
Fantastic. Yes. Okay, so thank you very much for the invitation. I'm really happy to be here and speak about the work that I did during my postdoc with Professor Faisal Mahmoud. And as you see, it's going to be about assessing allograft rejections for the patients with heart transplant. And I was also looking at the past recordings of this group just to catch up, but I think this might be like a nice extension of the discussion we had before about how to bring AI closer to clinical practice, or like how AI can potentially be useful for the Banff working group. So I hope it's going to be useful. And feel free to ask questions anytime. We can make it more like a discussion. Okay, so first bit of background, but just really briefly, because I think this is literally the most expert audience I'm ever gonna have. So we are basically looking at a patient with heart transplantation, and they are monitored for any signs of rejections, and the rejection can happen not only right after transplantation, but also a few years later, or like a decade later. And depending on the rejection type and extent, the patients are going to be treated with immunosuppressive medication, which are then tailored to patient-specific condition. And despite the medication, the rejections are fairly common, and they affect approximately 40% of heart recipients. Now, since the early stages of rejections are asymptomatic, the patient go regular endomyocardial biopsy screening, and the goal, or the gold standard, is basically manual assessment of H&E stain biopsies, and the assessment involves detection of the rejection, specifying the type of the rejections and the grade. Rejection grade, as you know, reflects the severity, and it can range from 0 to 4, where 0 is no rejection, and then the numbers from 1 to 3 are describing the increasing severity. In the terms of rejection, of the type of rejections, we have the acute cell rejection, antibody-mediated rejection, and all these rejections can coexist at the same time. So you can have patients that have both. And to make it even more spicy, we also have other things like these benign mimickers of rejection, such as QLTB lesions, which they are abnormal finding, in the sense they are not rejections, and they don't require changes in the medication, but still they're abnormal. And like looking at the latest report about the cardiac rejections from the Banff 2019, there's like a lot of discussion what to do with the QLTB lesion, but still it's abnormal finding, and it's included in the synopsis from the pathology. And the QLTB lesions can also coexist with all the other rejections. Okay, so maybe this slide is not relevant here, but in the case not everyone is cardiac expert, I just like to show briefly these different anatomies just to know what we are looking at. So here in the first column, we are looking at normal tissue. Everything is nice, smooth, symmetric, and this is how the acute cell rejection look. They are usually characterized by the presence of lymphocytes, all these purple guys, and you can see all the different involvement. This would be example of antibody-mediated rejections, which are characterized by like increased extracellular space and edema, which is the red arrow, and also like a changes in vasculature, which would be the green arrow. And this is example of QLTB lesions, which they are also involved like infiltrated lymphocytes, but this on its own, it's not rejection. But one of the main issues is that visually they are very similar to acute cellular rejections, and they may be confused. So this is very briefly. So now, looking at all these different types of rejection, we can probably acknowledge that assessment of rejection is not easy and not so straightforward. As for instance, if you compare the detection of cancer, like if you have models that are looking for the cancer diagnosis, usually the diagnosis is determined by the presence or absence of specific neoplastic morphology. But in the case of cardiac rejection, the disease manifestation, basically, it's going to be affected by the type of rejection, grade of the rejection, plus you have all these multiple factors that can coexist at the same time. And the extent of the rejections, I mean, the grade of the rejection is specified by the extent of the injury. That's kind of subjective, and it leaves a lot of space for subjective interpretation. And actually, there were studies that shows that less than 71% of experts agree if the patient is rejecting the heart, and less than 28% agree on the grade of advanced rejections. So basically, there is a lot of large amount of inter-observer variability, which of course is going to translate to, it's going to affect the patient. Basically, any misinterpretation of the biopsies can lead to under or overestimation, or under or overtreatment with immunosuppressive medication, unnecessary follow-up biopsies, overall worse outcome, and so on. So, I mean, you know this probably better than I. So our aim, how we could target this problem, was to develop AI methods that could provide objective and more automated assessment of the biopsies. That's the introduction. And so now, to address the problem, we are proposing cardiac rejection assessment neural estimator, or CRANE in short. Basically, CRANE is a deep learning model that takes as an input H&E stain whole slide biopsy, and it simultaneously identifies all these major diagnostic tasks. So it means for each slide, it's going to identify presence or absence of acute cellular rejection, antibody-mediated rejection, and cumulative lesion. And for each rejection case, it's going to also estimate the rejection grade. From the implementation point of view, Crane is basically multitask model because it's doing all this prediction at the same time for each slide. And it's also so-called a weakly supervised model, which means we use only patient diagnosis as only label rather than using any manual annotations of the slide, which has several advantages. It avoids the iterator variability in the manual pixel annotation, and also all the costs and all the issues involved with human annotations. And also because of this very low pre-processing cost, the model can be easily applied to larger cohorts and diverse datasets. So at the bottom, you can see the architecture of the model, and we can maybe briefly go through just high level, no equations. So the first thing to say about the whole slide images, they are huge from the point of data. One whole slide image can have like close to 1 billion of pixels. So it's really difficult to train the model on the whole slide on its own. And to handle this issue, what people usually do, we segment the tissue in the slide just to remove the background, and then the tissue region is divided into smaller patches. So like you can see it here. Now, if we have all these small patches, usually we use patches of size 256 and 256, but a patch on its own is still relatively large to run the model on it, especially if we have so many of them, like several thousands. So what we do is we would like to embed these patches in lower dimensional space. So basically, it means you would like to represent each image patch with a smaller vector of a fixed size. This is called embedding. And the idea is that this embedding is smaller size than the original patch, but contain the relevant information. In this particular case, we use ResNet-50 model, which was pre-trained on ImageNet, and we use it to extract features from the patches. So instead of having 256 times 256 times 3 big patch, like we're gonna have just vector of size 1024, just like to reduce the complexity. And then since the ResNet-50 that we use for feature extraction was actually trained on natural images, we include extra 3 fully connected layers just to allow the model to find you the feature to be more specific for the given task. So that's like the pre-processing step. Now, so we have the dispatch level embeddings, and the kind of issues, we don't have patch level labels, we just have slide level labels. So we know the diagnosis for each patient, but we don't know the diagnosis for each patch. So we would need to aggregate the information from the patches to obtain like slide level representation. And to do this, we use so-called attention-based learning or attention-based pooling. Just to explain it for simplicity, let's assume we have just one task, we have a slide, and we want to predict there is cellular rejections or not. So the idea of this attention-based learning is we're gonna train the model to teach or to score each patch in a way that this score is gonna reflect how relevant each patch is for making specific prediction. So here the figure on the side, you can see like different patches, and for each patch we assign score. The higher the score, the more important the patch is for making a specific prediction. And once we have this attention score for each patch, we can pull it together. So basically, we're gonna compute weighted average of the features from all the patches, where we weigh them by the specific attention score, which is here denoted as A. And putting it all together, we'll end up with a slide level representation, which for the slide or for the given patient, we already have the label, and the slide level representation is going to be used to make the model prediction. So this is all the magic. Now, if we have 3 tasks, as in this case, like predicting cellular antibody-mediated rejection and cruelty lesion, we're going to compute 3 attention scores, 1 for each task. And here at the bottom, you can see the attention model, just very brief graphic representation, and it consists of 2 layers, which is the first, this is the second layer. And the idea is that the networks in the first layers, they are shared across all the tasks, while in the second layer, we have a specific branch for each task. And the motivation here is that the idea of the first layer is to learn any atypical cardiac tissue, while the second layer is then going to learn what are the features specific for each task. That is just to divide the task. Okay, so at the end, we will basically end up with 3 different slide level representation, 1 for cellular rejection, 1 for antibody, 1 for cruelty lesions. And just having this whole slide level representation, the last step is to make like a classifier which gonna assign for each slide, is there cellular rejections or not, is there antibody-mediated rejection or QLT lesion. And for the slides that are identified as a rejection, we have another model with just the same architecture, but it's just gonna be predicting the grade. In this specific case, we are predicting low grade, which would be grade 1, and high grade, which is grade 2 and 3. We combine grade 2 and 3 together just because we have very, very little grade 3 cases, which I think is good for the patients. And also grade 1 usually doesn't require significant changes in the treatment. So this was just for the modeling purposes.
Mhm. Hi, this is Richard Levinson.
Hey, nice to hear you.
Oh, there, yes. So my question is, what are there cases where you can have 1, 2, or all 3 labels on a slide, like quilty and cellular?
Exactly. It can happen. You can also have all 3. I will show you one slide afterwards.
Okay, thanks.
But that was the motivation for having all this multitask too.
Got it. Okay.
Okay, perfect. So just to finish, like one of these advantages of this attention-based approach is that we can then map the attention scores that were assigned to each patch. We can map it back to the whole slide image, and we end up with these colorful high attention heat maps, which basically tells you which tissue regions the model considered to be most predictive for the given task. So you can use it for some way of interpretability of your model or exploring what's going on. And so that's the big picture of the model very briefly. And now for the study. So we collected large amount of slides we have over 7,000 whole slide images from 3 different cohorts, from US, from Turkey, and from Switzerland. And these different cohorts were designed in a way that they really express the large variability that exists in the histopathology data. So not only we have different populations, but we use different scanner in each center. There is different biopsy protocol, different staining, basically everything is different. Like for instance, in Turkey, they stain the slide manually, which leads to a lot of variation, while in Switzerland and US, we have automated staining, so you can see all the differences. And for the model design, we're going to train only on the data from the US cohort, and then for the testing, we use subset of the data from US, but also the two external cohorts from Turkey and Switzerland. And we don't do any attempts to like domain specific adaptation. We just want to see how this model on its own is going to generalize to different cohorts. It's like your baseline performance. Here is just like example where we can see the distribution of the colors across different cohorts. So you can like visually appreciate it, that the colors are very different, and intensities and saturations. Okay, so more to the results. So here we are looking at the model performance, where the first row is basically AUC curve, and the second is accuracy, where in the blue is performance on the local cohort from the US, and orange and green are the external cohorts from Switzerland and Turkey. And the AUC, and then you can see performance for each specific task. And the AUC curve is around 0.90 for most of the tasks, but of course you can see there is like quite a drop in performance when we go from the US cohort to the external cohorts. On the other hand, we can see that the model reached very comparable performance on 2 very different cohorts. So there is some signs of generalization, but for any like clinical deployment, you would like to reduce this gap. Maybe you would like to fine tune your model with your local data. This is just to see what is the baseline performance, what you would get with the native model without any fine tuning. And it's still like comparable to the humans, as we're gonna see later. So that would be the performance. Now the more colorful part, we can look at these interpretability maps and or the heat maps, and try to understand which tissue regions the model is looking at. And here you can see example of different slides and attention heat maps for each different task. And like if you look at the zoom region, we can see that the model is usually putting high attention to the regions with morphology that is specific to given task. Well, high is shown in red. And what is in blue, it's like a low attention, which usually is assigned to the normal tissue. And then this is the case where we have one slide, and it has everything. It has cellular antibody-mediated rejection and QLT lesion. And you can see the attention heat map for each specific task, and then like a zoom region. Now, what is interesting is like at a high level, the high attention heat maps look kind of similar for all three tasks because the model on its own, like naturally put high attention to any tissue that is not normal. So it's kind of similar, but what is great is that the model put highest attention to the region that is specific for each given task. So here we're looking at the region with the highest attention, and in the last column, there are patches extracted from the highest attention region. So despite that everything was present, all three diagnoses, the model was able to focus on the right tissue regions to make the diagnosis. And you can also see that it's able to differentiate it between cellular rejection and QLTB lesion. Then having these attention heat maps, what we can also do is to look at the failure cases. So here we are looking at the worst cases, worse in the sense, these are the cases where the model make wrong prediction with the highest confidence in each cohort. So all these cases contain rejections. The first three columns contains there are cases with cellular rejection, and the other three columns are cases with antibody-mediated rejection, but the model thought these are normal cases. But if you look at the attention heat maps, we can see that this is a very nice example. Despite that the model make wrong prediction, it still put high attention to the tissue morphology that would be predictive of the rejection. So at least we know the model is looking at the right regions. It just maybe the features were not sufficient. These are usually all very low grade rejection with small involvement. But at least we know the model didn't fail because it was looking somewhere randomly. It just wasn't convinced these are rejection. But it gives you some way to look at your model and assess what is the quality of the performance. So these are mainly like qualitative assessment of these heat maps. We were looking where the model is looking, what is red, what is blue. We also try to do some quantitative assessment of this interpretability method or these heat maps. Now, important thing is to say is the attention heat maps is not a segmentation of the rejection regions. This is just like importance of different tissue regions, how the model see it, like which regions are more important than the others. It's not a segmentation. So it's not that easy to quantify it, but we were looking how we can basically quantify diagnostic relevance of these attention heat maps. Anyway, so what we did in this case, we selected 30 random whole slide images from each diagnosis, and we computed attention heat maps as we see here. And then we did assessment at the patch level first, which means from each case, we extracted 3 patches from the regions with highest attention region and 3 patches that the model considered to be diagnostically irrelevant. And then we asked pathologists to rate each patch as relevant versus not relevant for the specific task. And then we can use this to compute like agreement between the model and the diagnosis. So you can see a UC curve, which is like across all the different tasks, is like how the model and pathologists agree on diagnostic relevance of specific patches. And in the subplot E, you can see accuracy for all specific tasks. So like for the cellular rejection and antibody-mediated rejection, then what we call here accuracy is like the agreement with the pathologists. It's really high it's a bit lower for the QLT lesions, but this can be attributed to the fact that in this case, pathologists have to look at the patches to make predictions. And it may be that patch doesn't have enough context to be able to differentiate QLT lesions and cellular rejection. But overall, there is really high concurrence between what the model thinks is important and the pathologist thinks is diagnostically important. And then we did similar assessment, but at the slide level. So in this case, we have the high attention heat maps, and we also ask pathologists to manually annotate tissue region in the slide that they consider to be diagnostically most relevant. And then we would like to compare how often the model and pathologists agree. Now, we don't compute like a dice score, as it would be in the case of comparing segmentations, because attention heat maps are not segmentations, and there may be like differences in the outline. But instead, we so here in blue is the segmentation by the pathologist, and in the black is the outline of the 10% highest attention regions. So this is what the model considered to be predictive. And we're going to look at the overlap between the predictive regions identified by the model and the pathologist. Basically, if they overlap, we will assume that they agree what is relevant. And for this task, for the detection task, you can see in the subplot H, there is like detection rate for all the tasks, which again shows really high concurrence between the model and the reader. Just some way to get some insight. Okay, so this is just a short video. So you can go to our website. There is like a demo for different rejections. And you can like download different slides, look at the tissue, look at the attention heat maps for different types of rejections for different patients. And you can also see the model predictions and the confidence for specific tasks. So you can go and play around. And so that's now we have the model. And the next question is like, how do we going to compare it with the human readers, right? Like how useful it is at the end. So to address these questions, we selected subset of 150 biopsies from the Turkey cohort, from this external cohort, and we recruited 5 pathologists, and we asked them to look at basically to assign diagnosis to these slides. And we would like to compare how the model and pathologists perform. Now, it's a little bit tricky because in principle, every human or every cardiac pathologist is seen as a gold standard. And at the same time, we know that pathologists sometimes don't agree with each other. So it's a bit hard to compare it. So like a first attempt of comparison, we are going to compute Cohen kappa, which allows to compare agreement between 2 pairs of observers. So first thing that we do, so first Cohen kappa is basically number from -1 to 1. 1 means like perfect agreement, 0 mean agreement by chance, and negative numbers like it's disagreement. And what we see here in the subplot C, basically for each pair of our cardiac pathologies, we compute the Cohen kappa for each task. This plot is a bit messy, but basically each dot mean the agreement between 2 pairs of pathologies. So here the blue is, and the first line is agreement between pathologist 1 and pathologist 2 on the rejection detection, while in the orange is agreement on assessing cellular rejections and so on. And the vertical line would be the average agreement on specific task across the pathologist. So what we saw that the agreement of our pathologists is comparable to what is reported in the literature. So our cardiac pathologists are representative. Now, and in the second step, we compare agreement of each pathologist with respect to the model, which is here on the subplot D. And we found that the model predictions are basically the model and the pathologists agree equally well as 2 pathologists between each other. So for instance, or sometimes even better. So for instance, for the detection of rejection, 2 pathologists agree with kappa 0.5, which is like moderate agreement, but the model and pathologists have slightly higher agreement with kappa 0.63. So from this point, we can conclude that the model predictions are comparable to the human readers, or they are not inferior to the human assessment. Even if we are looking at external cohort, the one where the model doesn't perform so well as compared to internal cohort. So this is first step, but now since we had 5 pathologists to look at 150 biopsies, we may attempt to generate grand truth gold standard labels, and this would be the second reader study. So now we take the assessment of the 5 pathologists from the first reader study, and we computed this grand truth as a consensus across all 5 pathologies, and we're going to use this as a grand truth labels. And what we are looking at now is like, we would like to know how this model can be used in a clinical workflow, or how it can be beneficial for pathologists. So we generated these grand truth labels, and we recruited another set of 5 cardiac pathologists, and we asked them again to assign diagnosis to the same 150 slides from the previous study. The only difference is that now we divide the pathologists into 2 groups, and in the pathologists in the first group use only whole slide images, and the pathologists in the second group are going to use whole slide images with the assistance of the AI model. And the assistance came in the form of these attention heat maps, which can be placed at the top of the whole slide image, basically the same as I showed you in the video. So pathologists can see the histology image, the H&E slide image overlay with the attention heat map. And after the washout period, basically and after the washout period, the pathologists basically switched the group. So the one that didn't use AI models now going to use AI models. And this would be the result. So what we are looking at, this is the accuracy performance. So each color is performance of 1 pathologist. The first column is the performance when the pathologists use only whole slide image, and whole slide image plus AI is when they use the AI assisting tool. And on the y-axis is the accuracy for the specific task, while in the last column, we see the assessment time. And what we can see here that for all pathologies and all the tasks using this AI assisting tool, it's going to increase accuracy across all pathologies and decrease the assessment time, which sort of makes sense. Like if you show pathologist whole slide image, but you highlight the regions which may be relevant for the diagnosis. It's going to make sure that everyone is looking at the same regions, and also it makes the whole task much easier or much faster. And since there is higher accuracy, it's also implied there is like higher agreement between the pathologies. So there is a potential way how this model can be beneficial for the pathologists. Now, this is like a brief summary, and then I have kind of more extended discussion. So just to summarize what we did for now, and then from this point, we're going to discuss what can be done next. So the problem we were looking at was addressing large inter-rater variability in the heart transplant biopsy assessment. And to address this problem, it's kind of a workflow that can be applied for other models. It's like there's, of course, the data collection, label preparation, model development. We put a lot of emphasis on the interpretation. We want to make sure that the model is looking at diagnostically relevant tissue regions. And we also want to know that the model is robust across variation present in different hospitals and different cohorts. And then we also look at a comparison of the model with the human readers and the potential of using the model as assisting tool with the pathologists together. And we wrote the paper. And the next steps would be like to apply it to the larger clinical trials and maybe bring it to the closer to the clinical deployment. I mean, this is the big vision. I think we are not there yet, but that's the flow. And this is maybe more like to lead for the open discussion. So like what we can do next and how we can make things better. So of course, one thing we can do is we can try to improve the model on its own. I know I went a bit quickly through the results, but the performance of the model on assessing rejection grade was a bit lower compared to the other tasks, still comparable to the humans, but there is a lot of space for improvement to improving the grading mechanisms of the model. And of course, the generalization across different cohorts, there is a drop in performance. And it's a general question in pathology, how we can make the model robust across all the variation present in the, these are the standard questions. How do we improve the AI model? And like possible next steps can we translate the model to different organs? And as Sharifa is going to present, maybe not next time, but in the near future, we translate this model to address transplantation, like rejection in kidney transplant, with all the specifics that came with the renal biopsies and all the different stains. But then can we expand more? Can we look at the liver? Can we look at the lung transplants? And maybe can we have one organ study? I don't know, but I don't know. Can we learn across different organs versus, I don't know, what we can do with multiple different rejection types. And the next step is like how we can improve the clinical utility of these models. It's great that the model can assist pathologists with the detection of the rejection, but what else we can do? One pretty obvious example is to train the model to make a patient risk stratification. If we are able to predict which patients are at high risk, maybe we can use it to optimize the schedule for the biopsies, like not to do the biopsy to patients that are at low risk, but monitor the patients at high risk more frequently. This is okay. This one is a bit tricky, and this is so in principle, what is very difficult in AI and human assessment is that we don't have good labels or the gold standard labels. I mean, there is this like a whole loop. On one side, we claim that the human assessment is prone to large inter-rater variability, and then we can use AI models to improve the assessment of the biopsies. But then we train the models using the labels assigned by the humans, and you can see the cycle. But if we could instead train the models using more relevant like endpoints, either for the biopsy or some patient clinically relevant outcomes as the labels, we may end up with more objective labels and those better models. And in turn, such models can maybe be used to help Banff working group to maybe refine the criteria for the classification or just to make like better decisions. And of course, we can go beyond the standard H&E. Like Sharifa will present, we can of course include IHC, but then there is the multiplex imaging, special transcriptomics, just to make the models more robust and more diverse. And of course, inclusion of molecular data can be a really good step. And just like a last thing is, these are usually all large studies that require a lot of collaboration And as we saw during the COVID, when people came together, things somehow happen faster. So I think it's really important to share the data, resources, and all the efforts just to make things happen faster and to minimize any like doubled work and all these issues. Now, this is my like a wish board for the transplant. And with this, I would just like to thank everyone from the Pathology group. And if you have any questions, we can now discuss. And I'm really curious about your suggestions.
Yeah, beautiful stuff. I was very here. I can even see if I can add a video. Yes, I was concerned about the fact that you've spent all that effort and thousands of slides with using flawed pathologists as ground truth, and wondered how you can efficiently move on from that. Maybe even circle back, use your classifier as ground truth, and then develop a new classifier.
Yeah,
would that work?
It may work in the terms of improving like robustness of the model, but it's tricky, right? It's like, because what is the ground truth in the first place?
Right. I also came up with a new term. Instead of ground truth, I think we're looking at mud truth.
It's very muddy.
And like what's going on in Ukraine. So, and the other thing is, I loved your slide of just showing all of the steps from the problem to the solution, and it looked like AI, but that would be academic intelligence. In other words, how do you do this effectively in an academic environment? So that was nice, but it's a problem. Yes, I mean, when you don't have good ground truth, how do you make things better?
But maybe we can look at the, I don't know, rejection rate, or I don't know, 5-year survival of the graph. Maybe more like, I don't know, it's basically the way how the classes are assigned by the pathologists in the first place, right? So maybe looking at the outcomes and use it to do, I don't know, different types of classes, maybe AI based, maybe, I don't know, some agreement between AI pathologies, clinical outcomes.
Right. I mean, pathology isn't truth. It's just a means to an end. And as you say, it was developed by doing exactly that, correlate what you see on a slide with what they know what happened to the patient. So do it again. Create all new diagnostic groups.
Looking at outcome is very interesting, because it's full of bias, of course, as well. Because depending on what the pathologist said, the patient undergoes treatment or not. So it might be that you're looking at the effects of treatment, or is it really the effect of the thing that you see in the biopsy?
I know. And then there is the patient compliance with the treatment, and I keep thinking a lot about this. But
have you tried ever to look at, for instance, soft labeling?
What do you mean by soft labeling?
Well, now we say this is rejection or this is not rejection, but maybe it's 80% rejection or 10% not rejection. And so to not make the label so hard. Did you try? Have you looked at something like that, or some procedure to take into account that people disagree?
I did not. It's very interesting. It's just like, I'm afraid when we go to percentage, it's gonna be even higher into rate of variability. But yeah, maybe for the that's maybe interesting.
I think it's a numbers game. So if one pathologist says it's a rejection, it's basically a 50-50 chance if he's right or not.
Exactly.
But if 20 pathologists say it's a rejection, it might be actually a rejection. It's a trick that you should never do in the casino, because they kick you out to count like that. But it might actually work here. The only problem is that for 7,000 biopsies, you need to revise them by many pathologists. And that is a humongous task.
Yeah, this is what we did for 150 biopsies in the human study.
Yes. So don't you think, just talking in very general terms, high impact education, which is what you're involved in at some level, changes human behavior. So although you're probably not inclined to say so, I think it is predictable that the way, pathologists act, the way they interpret slides will ultimately be changed by what you're doing. That's not just static and unalterable. So I'm not saying that you should talk publicly about that, because there might be a lot of resistance to that idea, but it's good keeping in the back of your mind that that's a logical conclusion of what you're doing, that, because of this, pathologists' behavior will change.
I fully agree.
Cool. All right. So that's the background that you will always know and you will seldom speak about, but it's fairly obvious. Yeah.
The other, I think it was mentioned, I'm not sure. The other issue is, you talked about patient compliance, but also the different medical systems have different resources and treat patients differently. So your outcome in UC Davis might be better or worse than the outcome in somewhere in Turkey. And then, of course, there's the overtreatment issue as well. If people are too aggressive here, they might, really damage the patients with all of the drugs and other interventions. What I was wondering about is, instead of having hundreds of pathologists do this analysis, is there how many different groups in your knowledge are working on AI and cardiac rejection?
I know about one more. So,
Well, you could then have them both evaluate the same lesions and somehow use that as an improved ground truth to go forward.
that could be, yeah.
This has been great. I think Lynn Cornell has a comment.
Yeah, I had a few questions and people have commented on some of these before, but well, first I was wondering, I'm a kidney pathologist, so I'm not that familiar with the heart, but it seems to me that heart rejection, like a bad rejection of the heart, is pretty uncommon. So how many of those did you have? Maybe I missed it, but how many of those, what
Okay.
percentage did you have?
I can tell you exactly. For the grade 3 rejection of antibody case, we have 1 after last 20 years, and for the high grade cellular rejection, we had maybe like 15 across all different cohorts, which was kind of the reason. So the grade 3 rejection is very easy for the model. I mean, grade 3 is like everything is already wrong on the slide. So this is kind of the reason why we combine grade 2 and grade 3 rejection together. So the model is like treating them as a high rejection. And then in the paper, we then design another classifier. It's going to separate grade 2 versus grade 3. But given we didn't have any high grade rejection, grade 3 rejection in the last like 6-7 years. So I don't think it's that, I don't know, useful. And also, like, use the pathologists, if I look at the grade 3 rejection, is very obvious. I mean, you don't need AI model to guide you. Just like the whole slide is going crazy.
Could you stop sharing your screen so we could use facial recognition software to figure out who's talking?
And then one thing that is an advantage of these kinds of models and scan slides and being able to do these kinds of analyses is that we could put rejections on a continuous scale. For example, I'm looking at a biopsy this morning and I'm trying to decide, is it borderline acute cellular rejection, or is this is in the kidney, of course, but is it a borderline acute cellular rejection, or is it inflammation in areas of fibrosis? Like, is it enough to call it, a rejection? I'm not sure, but it's like, we put a hard cutoff, we call it borderline, which is also supposed to be, borderline between no rejection and actually having a rejection. And it always puts us in this awkward position, like, well, is there 9% inflammation or is there 11%? And, I'm not calculating if it's 9% or 11%, but one advantage of these things is that you could have something on a continuous scale. And then, as you said, look at outcomes. Of course, patients are treated, but, at least in the kidney, well, at Mayo, where I work, we have follow-up biopsies from patients. They have rejection, and then, usually they're treated if it's a borderline or whatever. And then they have a follow-up biopsy about 2 months later. So anyway, it would be interesting to look at outcomes and then try to go back and redefine what rejection really is, because we have these kind of arbitrary cutoffs, whatever we think is. And again, if it's like you said, if it's really bad rejection, well, then it's obvious and you don't need some kind of model to do that.
Yeah, but there's a really good point, because you also have multiple time points. Just for the sake of this study, we treat each biopsy separately, but you have multiple time points and you know what's happening with the patient. And if there is rejection today and rejection next month, then you can confirm the first one was rejection. Yeah.
And I'm really glad, I just wanted to comment, I'm really glad that you involve different centers. And I think maybe not just because maybe practices are different and it increased your number, but also the preparation of the slides in different pathology labs, that could affect interpretation.
That's definitely
slides.
And there is like another thing, like there are different ways that try to reduce the or improve generalization of the model across the cohort. And I of course try them. I mean, I try everything. But the problem is there are methods and they help with one cohort, but not with the other one. So it's really generalization that is general across different cohorts, not just two cohorts between each other. It's really hard, and just show me how difficult it is.
Yeah, but I'm excited to see what your kidney work will be.
With the variation of the pathologists in the labeling, the mislabeling, let's say, do you think this is the maximum that we could ever see for heart rejection? 0.9 sounds good. You say you were not so convinced, but taking into account that mislabeling is probably a big issue.
Mm. Well, depends. Right now, the model compares to humans, but if you want the model just mimic what humans do, then we don't really need it. Right? So it would be really good if we can push one step further. I don't know, maybe I keep thinking about including like either molecular profiles, or can we just find different ways to assess the rejections, maybe from blood or something, and using these like AI models to look to search for the correlation. I don't know. So I am answering too many things at once. So I hope we could do better than what humans do, and that the models can in some way not just mimic what you do, but make it a bit better. And then maybe find the less invasive ways, like another suggestion, like, but I don't know.
At least for kidney, it seems now that the molecular analysis is really in line with the severity of all the lesion scores. So now we're stuck, because also that doesn't give us the answer. Yeah, it's a difficult issue. They're all surrogate endpoints, of course, and you end up in a, let's say, in a vicious circle.
Exactly.
That doesn't bring you further. And it's the same discussion that we had, I think, the past 5 years with the molecular analysis on the molecular microscope. Yeah, it seems to be better than pathologists, but we don't know because we don't have ground truth. And so you get stuck. Yeah. So are there any clinical trials planned already to assess this in clinical practice?
So the things that we tested was to use the model as assisting tool with the pathologists, which I think is the easiest way how to bring to the workflow, because I wouldn't feel confident just to drop it in the to make diagnosis on its own. So we don't really plan some trials right now, but then, I mean, not at this moment, but the next step would be to see how pathologists can really interact with it prospectively, and does it help them, or is it like just disturb everything and they don't want to look at the slides? Or so I think there are like too many steps in the way, like how to introduce it to make it helpful. We hope that maybe this attention heat maps on its own can at least pinpoint the predictive regions, which are already gonna increase the agreement between pathologists. And yeah, there are a lot of questions to be answered. And then you get to all this other stuff, like who is looking at a slide first? Like, pathologist or the model? Who is going to affect
Yeah.
whom?
Yeah, I think there's one quite big issue as well with the assessment of the added value of AI, is that we as pathologists, that we don't just look at the slide. And we are trained physicians, and to give an example, if the PSA value for prostate cancer is 0, you don't even have to look at the biopsy. It's not a cancer. If it's through the roof, yeah, it's cancer all over the place. So we take into account, of course, what our clinicians tell us. And I'm saying this because what I find with companies that now try to commercialize the prostate cancer algorithms, also whole slide image, let's say level weekly supervised, is that it actually, if you actually test it in clinical practice, we tend not to miss that much as compared to a blinded assessment, which is quite interesting. I think there was a study from Ibex, this company from, I think it's from Israel. And they basically show, I think they could, if I remember correctly, they could show one case where the AI detected tumor and the pathologist missed it, but on quite a large set of biopsies being assessed. And of course, if you, it's always also the question of what's the business model for these things, and how many, let's say, slides should you have assessed by the AI model to pick up one rejection that would otherwise have been missed. It's almost philosophical, I think, how we should get these things in clinical practice. It's very interesting.
Yeah. Also,
and of course, you single shot at detecting these diseases. The patient will come back in 3 months, and you evaluate them again and say, "Oh, sorry, we missed it." And yes, you are,
bit of fibrosis.
I did want to ask a question about fibrosis. As some of you know, we in our lab we've developed a Duet, which is basically just a fluorescence imaging of H&E stained slides, and we can see collagen with really high sensitivity and spatial resolution, better than the chemical stains. And I was just wondering whether a collagen signal is important for cardiac rejection analysis.
Right, so I'm not a cardiac expert, but the word collagen wasn't mentioned in my old study, so I think not. I mean, from what I hear from my pathology, I think maybe in kidney it's more relevant.
Yeah.
Actually, in the heart, it looks like it's mucin. Actually, if you look at your image that you share now, there's a lot of mucin actually in between the bundles. Yeah. Maybe you could do something with that, Richard.
But I think
I suspect
useful.
it could be termed edema as well. One of the things about when we look with our other slide thing with Phoebe, because it's not dehydrated, you can actually see a lot of water deposition in the tissue that goes away when you make a slide.
Can imagine. Yeah.
Yeah, but any molecule or any extra information you could include should help the model to differentiate, because now everything is kind of rejection, but even for the different grades, maybe there are some subcellular changes. That would be, it would be great.
Oh, very nice work.
Yes, this was
very
a
nice,
great,
very clean presentation as well.
Yeah, your presentations, your slides were beautiful, and the work is very elegant and well illustrated and thought out. So thank you so much.
Thank you. It was really great discussion.
Yeah. Any last questions or any comments? Well, we might
maybe a brief comment. I think in general we should. This is something that I really see the role for this working group, is to create the validation or test sets for such models, to make it diverse, many centers, really a benchmarking data set that we can test multiple models and multiple applications in. I think that's really key in bringing this field forward.
Yeah, definitely. Yeah, that's a great. You were going to say something, Jana? I'm sorry.
No, I fully agree. I'm now looking at like what we learned from the COVID, like another project, but there was so much like everyone make everything public about the COVID, everything, we share the data. There was a committee that tried to make sure people don't reproduce the work. And just like this, when everyone came together and wanted to improve stuff, I think this is something we may want to do here. That would really help. Not sure how to achieve it, but and it's gonna cost money, but it would be really great.
I think Brad is on the phone.
Mhm.
Let's see.
Okay.
You're
well,
almost there, almost 5 o'clock. Yeah,
Yeah, 4 minutes left.
4 minutes.
Yeah.
Any philosophical input, Kim?
Oh, always, yes. There's no limit to how big you can think. Remember that. Even young people. Yeah.
Okay. Oh, well, thank you all so much. If there are no last week, we may even sometimes, would it be okay if we sometimes put this on YouTube? Would that be okay?
Absolutely.
Okay. Okay, good.
Wow,
Yeah,
cool. Yeah,
Great,
no,
great.
that-
Well, thank you so much.
That's wonderful. Thank you.
I think this was worth it. So we'll try to do that.
Thank you very much. It was great, great discussion.
Thank you so much.
Have a good day.
Take
Bye.
care.
Okay.
Thank you. Have a good day.
See you all later.
Thank you.
Take care.
Take care.